Hello, this is Kendra Cundiff, and this is my episodic SOAP note presentation. My chief complaint was sudden attacks of nausea, vomiting, dizziness, and diaphoresis. History of present illness. JH is a 42-year-old female who presents to the clinic with the chief complaint of sudden attacks of nausea, vomiting, dizziness, and diaphoresis. The episodes began approximately 9 months ago and occur at random with 10 attacks in the last 9 months. Episodes usually last about an hour and start with right ear fullness and ringing, then progress to debilitating dizziness, nausea, vomiting, and diaphoresis. She states that the attacks happen at random times and that she is unable to function when she is having an attack. Nothing makes it better or worse. She states that she's often exhausted for 1 to 2 days after an attack. Over the last 2 months, JH has noticed continued ringing and fullness of the right ear, along with decreased hearing in the right ear. Denies fever, chills, trauma or head or ear injury or headache. Current medical conditions. Patient was diagnosed with hypothyroid in 2005. Medication allergies to sulfa, which causes a rash, and current medications include multivitamin 1 tab daily and levothyroxine 125 micrograms daily. Past medical history: surgery, a C-section in 2006, immunizations, influenza, October 5th, 2016, Tdap, October 2014, gynecologic and obstetric G1, P1, and is currently perimenopausal starting around 2014. She is an only child. Her mother is age 73 and is living with a history of Meniere's disease diagnosed at 48 and hypertension. Her father is not in the picture, and she believes he's around 78 years old, but does not know if he's living or any of his past medical history. Patient denies alcohol, tobacco, or illicit drug use. Review systems: general, denies fever, chills, cardiac, unremarkable, respiratory, unremarkable. HENT, intermittent right ear fullness and tinnitus, decreased hearing in the right ear. Patient denies pain. Neurointermittent dizziness, which is rotational, which is associated with nausea, vomiting, and diaphoresis. Vital signs: blood pressure 122/88, pulse of 68, respiratory rate of 18, with a temperature of 97.8 Fahrenheit. Patient's 5'7", 155 pounds, with a BMI of 24.3. Physical exam: stress alert and oriented ×3. HENT, skull is normal cephalic, adramatic. No redness or bulging. Weber, localized to left ear. Rhine, positive. Air conduction greater than bone conduction in the right ear. Air conduction equal to bone conduction in the left ear. No sinus tenderness. Septum midline, nasal mucosa pink. Pharynx without exudate. Trachea midline, thyroid palpable, normal size and shape. No masses. No cervical lymphadenopathy. Neuro, purple, pupils equal, round and reactive to light. Face is symmetrical with sensation intact. Tongue midline, cranial nerve 1 not tested, cranial nerve 2 through 7 and 9 through 12 intact. Cranial nerve 8, abnormal whisper test in the right ear, left whisper test intact. Tone, strength 5 out of 5 throughout. Finger to nose, heel to shin intact bilaterally. Normal gait, normal balance. Reflexes 2+ throughout. Heart, regular rate and rhythm, normal S1 and S2. No JVD, murmurs, gallops, or rubs. Lungs, unlabored respiration. Chest expansion symmetrical. Lungs clear to auscultation bilaterally. Diagnosis: based off the past medical history, the history of present illness, and the physical exam and reviewed systems, I suspect that my patient has Meniere's disease. However, there is some criteria that needs to be met before I'm able to officially diagnose my patient, and I will be talking about that next. So Meniere's is an idiopathic disorder of the inner ear, and it includes attacks of vertigo that are spontaneous and recurrent with fluctuating hearing loss. The etiology, the exact cause is unknown, but there seems to be a disruption of the normal homeostasis of the inner ear that can contribute to Meniere's disease that include genetics. If a first-degree relative has Meniere's, there's a 50% chance of the patient having Meniere's as well. Inflammatory and immunologic, inner ear autoimmune process, viral infections, syphilis, Lyme disease, hypothyroidism, trauma, vasculopathy, endolymphic sac dilation and ischemia, fluctuations of electrolytes. The pathophysiology of Meniere's disease, endolymphic hydrops, which is distortion of the membranous labyrinth of the inner ear, is thought to cause the symptoms of Meniere's. Also, there may be a dysfunction of cellular channels and a dysregulation of the ionic composition of the endolymph. Also, degeneration of the inner ear due to multiple insults is thought to cause hearing impairment and vertigo. Risk factors for Meniere's disease include the family history, which we talked about a little bit ago. Possible triggers for attacks include barometric pressure changes, allergy attacks, stress, hormonal changes, sleep deprivation, diet changes, and excessive perspiration followed by large volume fluid replacement. Prevalence among age, genders, and cultures. Usual age is 30 to 60. It's males and males, and the incidence is about 190 per 100,000 people. Most common symptoms related to Meniere's disease, there is the classic triad that is seen in Meniere's, which includes vertigo with spontaneous onset that lasts usually between 20 minutes to 3 hours, fluctuating sensorial hearing loss that's usually unilateral, so trouble hearing low frequency sounds, and ipsilateral tinnitus. Patient may also experience nausea, vomiting, and diarrhea, diaphoresis, from the vertigo, and the patient may be asymptomatic between attacks. Essentials Evidence Plus, the American Academy of Otolaryngology and Head and Neck Surgery requires 4 things for a definite diagnosis of Meniere's. So the first one is at least 2 spontaneous episodes of rotational vertigo lasting at least 20 minutes. Audiometrically confirmed sensory neural hearing loss, and so this is why I'm unable to diagnose my patient today with Meniere's until my patient has a hearing test confirm it, or oral fullness during an episode, and exclusion of other possible causes of vertigo. Differentials include migraines. A migraine can mimic early Meniere's. Usually the patient has a headache during or after an episode, and the patient may have dizziness and vertigo associated with the migraine. Hearing loss is usually mild and stable, not progressive. Another differential is benign paroxysmal positional vertigo. The vertigo associated with this usually only lasts a few seconds to a few minutes and is elicited by head movement. There is no associated hearing loss or tinnitus or ear fullness. It is unilateral high-frequency hearing loss, which is progressive, not fluctuating. Usually the patient experiences more of an imbalance than true vertigo. But according to the treatment guideline in Dynamid Plus, it must be ruled out by MRI for all patients with suspected Meniere's. So this is another reason why I am unable to diagnose my patient with Meniere's. I'm unable to fully rule out acoustic neuroma until we get the MRI results. Vestibular neuronitis or labyrinthitis results in spontaneous vertigo, and the patient is usually unsteady for days after the attack. And the attack usually begins with a long episode followed by shorter episodes. So my plan for my patient today, she's going to need an MRI of her brain and acoustic meatus to rule out retrotrochlear disorders. Also, we're going to take a look at her TSH since she does have a history of hypothyroidism. We need to make sure her levels are within normal limits and could not be the cause of some of the symptoms she's experiencing over the last few months. Medications. My patient definitively with Meniere's today. I still plan to treat my patient's symptoms, and betahistine is the medication I've chosen to treat my patient's vertigo with. 16 milligrams, 1 tablet, 3 times a day, and compazine 25 milligrams PO every 4 hours is needed for nausea and vomiting. I plan to refer my patient to an audiologist to have that pure tone audiogram in order to get the official diagnosis of Meniere's. I also plan to have my patient follow up in 2 to 4 weeks for reevaluation of symptoms and medications, and also to review the results of the lab work, the MRI, and the audiology appointment. My patient will be instructed to return sooner for ear pain, ear discharge, severe headache, or sudden deafness. On the medications, that she should take them as directed. Beta-histine has very few side effects and usually are just GI-related complaints. Compazine should be administered with milk or food to minimize GI distress. Common side effects of compazine include dizziness, drowsiness, dry mouth, blurred vision, constipation, and urinary retention. And the patient will be instructed to use the compazine just as needed for symptoms and not on a regular basis. And patients with Meniere's should consume a low-sodium diet. Low-sodium diets have been found to help with the vertigo associated with Meniere's. So my patient should restrict her sodium to 1 to 2 grams daily. Also, restriction for caffeine and alcohol. And the patient should be educated and given rehabilitation, such as the Brent Dart-off exercises and the cough and courtesy exercises. These are exercises that help prevent vertigo. So the Brent Dart-off is sitting laying to one side, sitting back up and laying to the other side. And the cough and courtesy exercises include eye movements, head movements, and body movements. It should also be educated on safety, to not drive while having an attack, or if driving while having an attack, they should pull over and wait for it to pass. The activity until the episode has passed and they're feeling better. Disease prevention. Since Meniere's is idiopathic with a strong inheritance pattern, there's no real prevention methods for this disease. The goal is to prevent attacks, and they're often debilitating, and also to try to prevent any further hearing loss. Patient can help prevent attacks through stress relief and regular diet, sleep, and exercise, along with taking prescribed medications. So the treatment guidelines in Dynamed Plus and Essential Evidence Plus recommendations, both of them talked about a low sodium diet and avoiding caffeine and alcohol, rehab. Dynamed Plus listed beta-histine as a good option for treatment of vertigo in patients with Meniere's. Also, a study by Lizis et al. Found that high doses of beta-histine, 288 to 480 milligrams a day, patients with severe Meniere's who did not respond to lower doses. Participants in the study had very few mild side effects that included gastrointestinal complaints, fatigue, and altered taste, none of which were severe enough to discontinue the higher doses of this medication. This medication is a good option for the practitioner because they'll be able to titrate in order to provide better symptom relief for the patient. And since it does have very few side effects, it's a good option for all patients. Plus, talked about diuretics being used widely. Dynamed stated that there was strong evidence that the strong evidence for efficacy is lacking for diuretic use in Meniere's. And you must be careful not to restrict the patient's sodium too much when they're on diuretics. And also, they're going to require frequent checks of their electrolyte panel while on diuretics. Also, diuretics may have adverse effects, especially in the elderly. So it's a medication that should be used in caution. Listed in both guidelines were vestibular suppressants with anti-nausea effects such as Zofran and Compazine. Dexamethasone can be used for sudden hearing loss and can be administered either oral or intratympanically. It can also be used for vertigo that is unchanged by lifestyle or other medications. Surgery is an option for severe Meniere's disease that's not treatable with medications or lifestyle changes. Sac surgery for patients with this debilitating vertigo, and Minette's device for positive pressure therapy to help relieve vertigo, along with ventilation tube placement. and also a option is a surgical labyrinthectomy. Also, vestibular ablation can be performed to help treat Meniere's, and that's used in severe cases, and they use intratympanic gentamicin. Both guidelines recommended considering referral to audiology for hearing aids or cochlear implants to improve hearing loss associated with Meniere's disease. So here are my references, and here are my prescriptions. And thank you for watching.